Here for Adam.
Thanks guys, and thanks to Quentin, Dillon and the team for putting on this great event. And who today had a different approach to snowboarding or skiing after Charlie's event or our talk on risk? Did anyone just go, fuck it, why not? I'm gonna go for it. There's orthopedic injuries out there. I wonder if Charlie's being slagged off right now, the bastard. So my background, I'm ED consultant, rural generalist, work between Mount Isa and Cairns hospitals. In the past, I've done some work at some of the big festivals around Australia and dealing with quite a lot of drug-induced problems. So hopefully this talk will have something for everyone from the paramedics, ED doctors, ED nurses, and I'll be talking about some of the acute, the chronic and the behavioural issues with some of the more common drugs in Australia. So roughly going to be talking about the uppers, the downers and the psychedelics being the roundy-rounders. But keeping in mind that it's quite uncommon these days for someone just to have one drug in the system, and it's usually a little bit more like these scallywags here.
We had 2 bags of grass, 75 pellets of mescaline, 5 sheets of high-powered water acid, a salt shaker half full of cocaine, a whole galaxy of multicolored uppers, downers, screamers, lappers, also a quarter tequila, quarter rum, case of beer, pint of raw ether, 2 dozen needles. Not that we needed all that for the trip, but once you get locked into a serious drug collection, the tendency is to push it as far as you can.
So through the talk, you're going to be looking at your physiological toxicity, so is this drug actually going to poison you directly, and how much of its bad effects are by making you act like a complete dickhead. Some of them will be down here, up here, down there, or kind of up in the northeast corner. So there's a drug called methamphetamine. Some of you may have encountered this. It's a wonderful drug, makes wonderful people even better. So physiologically, non-toxic, bit toxic, highly toxic, what do you reckon? Yeah, I kind of put it about here. Death by being a wally brain. Yeah, probably up here. So it's probably up in this area here. So meth in Australia, I was quite surprised that it's only about 1% of the population have used in the last year. Certainly if you work in IED, it seems like a lot more than that. Increasing use of IV drugs, so it used to mainly just be smoked, snorted or swallowed, but IV drug use is becoming a lot more prevalent, especially in more socially deprived areas. Unlike a lot of the drugs we'll talk about, the age range just isn't in the 18 to 30 groups, so very wide age range, which kind of shows that meth is for life. It's more of a career drug, and you see a lot more of the chronic consequences. So it's estimated that 12 tons of this lovely substance was used last year, which equates to about 250 million 50 milligram doses, which is about 10 doses for every person in Australia. It's been implicated in just under 500 deaths, but again, it's hard to say what's meth, what's multifactorial, so like a lot of the drugs we'll go through, it's usually a combination of many things. So, methamphetamine mainly works on the dopamine pathways, so it causes a huge surge, causes your presynaptic neurons to dump huge amounts of dopamine into the synapse, makes you feel 10 foot tall, hilarious, you know everything, no one can beat you. But the come down is really quite bad, and this is also important for the chronic toxicity because it really damages the neurons. So The come down will be the opposite of the up, so depression, apathy, agitation, low self-esteem. This can last for several days, and in chronic use, this causes chronic problems, which we'll touch on later. I won't bore you. So, with drugs of addiction, the quicker the onset, quicker the offset, the more addictive it is. So, when you smoke it or use IV, the onset is in under a minute, so it's a huge rush. It's like just jumping through a vortex, I've been told. Smoking bioavailability is about 50%, IV 100%, so all those smart methamphetamine users who want to save a couple of bucks, maybe mug a few less grannies, break into a few less houses, or maybe just have twice as much fun. Have started using IV and all the problems that entails. So, mild toxicity, diazepam and olanzapine. So olanzapine has dopamine blocking effects as well. So if somebody's a bit agitated, not really being overly threatening, then that's usually my go-to. And something that's not often talked about is the role of acidifying your urine. So amphetamines, including MDMA and methamphetamine, are alkaline. So when you make your urine acidic, it creates a chemical, electrochemical gradient and pulls it out of your bloodstream a lot faster. So reduce the half-life by about 30%. But of concern is an alkaline urine can increase the half-life a lot more, up to 30 hours. So I'll usually give people a handful of vitamin C's at a festival and hopefully get them through it a little bit quicker. So the acute toxicity and the life threats. So the LD50, or the dose to kill 50% of the population, is about half a gram, and that's in a methamphetamine naive adult. And deaths occur at a lot less than that dose. So the acute problems, so probably the main one to look at is vasospastic angina, where the coronary arteries spasm due to over alpha stimulation. It's also very arrhythmogenic. People can go into AF, even into like malignant rhythms like VT, VF. Takotsubo cardiomyopathy, you've got so much catecholamines pumping around that it's probably an underestimated effect. Malignant hypertension, leading to subarachnoid hemorrhages, aortic dissections. So anyone who comes in with a headache or chest pain, do take it very seriously. Hypothermia is, again, really common, as is dehydration, especially Cairns, Van Isa in the summer. Your metabolic demands are highly elevated, and plus you're being a bit of a dickhead. You're not drinking water, you don't slip, slop, slap. You're running around doing all kinds of silly things through the day, so it's quite common to see AKIs, rhabdo, electrolyte abnormalities, and even things like DIC. CNS manifestations, so I've seen a couple of subarachnoids, mainly from hypertension, vasogenic edema, breakdown of the blood-brain barrier, more of an infectious disease problem, but then if you're using IV drugs, your blood-brain barrier is disrupted, there's a lot higher risk of bacterial abscesses. Chronic toxicity, often underlooked, but when you have such high amounts of circulating catecholamines for so long, especially as this is more of a lifestyle, dilated cardiomyopathy, accelerated atherosclerotic plaques, it is quite inflammatory to your vascular endothelium. And I think one of the really sad things is the neurotoxicity. As I said before, there's a lot of dopamine. Neurons are affected, and it can induce a state of Parkinsonianism. So you see people who are really quite dysarthric, cognitive decline, and unfortunately those neurons are the higher functioning areas that normally, if somebody's trying to quit, they need a lot of frontal lobe capacity, and methamphetamine takes that out. So great news if you're a dealer, and not so good if you're trying to get off it. So the management of severe toxicity. So I think most people here have experienced your angry meth head that's trashing your department. And just my advice is just go hard early. don't mess around. Droperidol is good, but even IV droperidol takes about 15 minutes to work. IM droperidol about 20 minutes before you start seeing sedation. I'd much rather go with Midaz straight off the bat, 10 milligrams IM, and that works within about 5 minutes. Giving a high dose of ketamine also has a similar effect. Now, one of my tips for this is to pump the muscle. So if you use the deltoid for the injection, just really activate that muscle. So when you're sympathetically driven, you divert blood from inactive muscle to active muscle. So if you give that injection and you really start trying to push down the arm and they start lifting up the arm, just pump that muscle. The blood supply to that will increase. By an order of magnitude, those drugs get into the system a lot quicker and you have a safe, calm, lovely patient instead of a screaming psychopath. Sorry, upset young man. Benzos will get you out of most things, and look, I think people are scared to give high dose of sedation because they're worried about the airway, but very unlikely that with droperidol and midazolam you'll knock off a patient's airway. And if you do, you're in an emergency department. It's what we do. Don't be afraid of the airway. Be afraid of some method, stabbing your security guard, your doctors, your nurses. That's what does the real damage. If you can't take an airway in ED, you might be in the wrong profession. So don't be afraid to drop these people heavy and early, and just be prepared to take the airway if it happens. It's never happened to me. So vasospastic angina, so that's when your blood vessels spasm, so use of GTN, or an IV cardiac calcium channel blocker like diltiazem, 10 to 20 milligrams IV. Avoid beta blockers. Your coronary vessels are dilated on the beta receptors. So if you give the beta blocker because the patient's heart rate is sitting at 180, then you can precipitate vasospastic angina. And just remember, fluids, cooling, electrolyte replacement. MDMA. Does anyone know this guy? I mean, not personally. Everyone awake? So apart from dancing like a complete turkey, and death by social media, where would people place MDMA in terms of physiological toxicity? Say yes? Probably about here. Death by misadventure, fairly rare. A couple of people hug stinging trees up in Cairns, but apart from that, it's usually okay. But with MDMA, the media attention is a lot more acute when you have a young, middle-class person who dies at a rave, rather than your screaming meth heads, which the media doesn't seem to care about. We'll touch on politics a bit later. So 2% of the population have used MDMA in the last year, twice as much as meth, and 14 in their lifetime. Usually a younger population, and it's been implicated in about 20 deaths per year, but again, this is mostly polydrug overdose, so it's hard to blame a single agent. So it works on serotonin and reduces oxytocin release, which gives you that kind of love feeling. It's not considered to be addictive, and hazardous use is atypical. Lasts for about 4 hours, and the onset's about 30 minutes. So here's our friend again. So you can actually get a figurine of him from Mixmag. That just made me so happy, and if anyone wants to get me a present, I will definitely have them on my desk in the office. So oral diaz will get you out of most situations, and again, as with MDMA, giving vitamin C, just a handful of tablets, will help excrete that through the kidneys. So the severe toxicity is kind of two main areas. So serotonin syndrome, which I think most people are fairly familiar with, and that's typified by mental state changes, autonomic stimulation, so heart rate, diaphoresis, diarrhea, and neuromuscular excitation, so rigidity, clonus, hyperreflexia. Most people who take MDMA will have some of these there. It's just part of the drug, so they might seem a bit elevated, a little bit confused, but I think really disorientated, hyperthermia, and certainly clonus, so more than 5 beats of clonus would make me really quite concerned. The other one is hyponatremia leading to cerebral edema, which can lead to brainstem herniation and death. So MDMA causes release of antidiuretic hormone, also known as SIADH. This is unique to MDMA and not meth, and this just increases your total body water. People are drinking lots of hypertonic fluids, and their sodium drops, and it can lead to reduced GCS, headache, neurology, seizures that are often self-limited and recurrent, and then ultimately brainstem herniation. So serotonin syndrome, in a nutshell, benzos, and more benzos if they're getting hot, over 38.5, then active cooling, ice packs and axilla, cold sprays, and if they hit 39.5, then paralyze them, take the airway, because it's muscular rigidity that's driving the hypothermia. The cerebral edema, so I think it's probably more important for the paramedics. So if you go to an event or a rave where somebody's collapsed, having taken MDMA, my recommendation would be to treat empirically as hyponatremia. So people are adverse to using hypertonic saline because of the fear of osmotic demyelination, and this occurs when you're chronically hyponatremic. There's not that many people taking MDMA at parties who have chronic liver failure, heart failure, renal failure. They're usually a fairly healthy bunch. If you do not give it, they can die. If you have access to a VBG, then absolutely use it, but you're pulling out the 3% as you're doing it. If you're wrong and they aren't hyponatremic, if their sodium's 140 and you make it 145, no big deal. It's not going to cause any harm. So early treatment is absolutely life-saving, so I'd highly recommend that as part of your practice. Consult local guidelines. So quite a few interactions of MDMA that can cause serotonin syndrome. But MAOIs are pretty uncommon, but very dangerous. And drugs like tramadol, methadone have serotonin reuptake inhibiting properties. Zybans, so the quitting smoking medication, can cause it as well. But interestingly, the standard SSRI antidepressants don't generally cause serotonin syndrome because they actually they bind more avidly to the serotonin receptor in the presynaptic membrane. So they actually block MDMA entering the vesicles and causing the huge dumping of serotonin. It can be unpredictable, but generally doesn't occur. I feel if it did occur, we'd see a lot more deaths given how prevalent antidepressants are currently. Do you know what this is? A narco-sub, thank you. So this was found in the Solomon Islands last year, en route to Australia. They estimate anywhere between 8 to 10 tons of cocaine, so it's very big business. Physiological toxicity, where low, medium, high. Yeah, probably about here. People can die directly with the toxicity. Death by misadventure, not as bad as meth, probably about here. You can do some silly stuff, but it's usually not too bad. So 45% of the population have used it in the last year, typically young fellas and in higher socioeconomic groups because it's bloody expensive. The numbers I had for the estimated use seemed far below what I'd expect, given like 8 tons have been seized, and I expect a lot more has got through. And the only data I could find was 2021, where there was 81 deaths, again, multifactorial. So, cocaine has a similar kind of effect on the brain to methamphetamine, but it's a lot less dangerous and a lot less chronic toxicity. So mainly dopamine, serotonin, and adrenaline lasts for about 45 minutes, and it's usually always snorted. So the toxicity, so ENT surgeons will use cocaine as to pack the nose. I'm not sure why they don't use cofenocaine. We should maybe ask them. No judgment. But they use that because it's a local anesthetic and it causes vasoconstriction, which fits nicely with cocaine's toxicity. So it is a sodium channel blocker, so similar to drugs like lidocaine and bupivacaine, it can cause arrhythmias and seizures. They estimate about 3 milligrams per kilo, and that would be an IV dose. Also causes prismental angina, so the vasoconstriction effects, again using GTN or calcium channel blockers. Which actually, in Australia, to get to the sodium channel blocker drug, you must be fucking loaded. If you're snorting a whole gram in a one, yeah, it's... Other more chronic causes, it does cause inflammation of the vasculature, so increased rates of MIs, not just prismental angina, but fortunately has a lot less neurocognitive problems. It's a lot more gentle on the neurons. It doesn't cause anywhere near the same toxicity as methamphetamine. GHB is making a comeback. Thank you. Where do you put physiological toxicity? High, medium, or low? Probably medium to high. Death by misadventure, probably fairly low. You're usually fairly sedentary, slothing around the floor. Typically comes in these little soy sauce containers or little vials. Not that many people use it, about 0.2% of the population. It's increasingly popular and people use meth as it does help restful sleep. It's cheap, produces sedation, euphoria, sexual arousal. One of my best friends actually takes it every night. He has a rare form of narcolepsy and he takes Xyrem, costs the taxpayer $30,000 a year in the special access scheme. I'm sure they could talk to someone in a hoodie out the front of Kent's Hospital, save himself a bit of money. But it's all above board, and he's doing really well on it. So the pharmacology, so the main thing about GHB is it's got a very narrow therapeutic window. So less than 2 mil will have minimal effects. Above 3 mils, you start to knock off your GCS, and above 3.5, then essentially you're comatose. Given that it's probably fairly easy to dilute and concentrations vary, it'd be very easy to make a mess of that dosing. It can even change based on temperature, so its equilibrium can shift. So it's a bit of a moving target, and that's why you see so many GHB overdoses that are unintentional. It works on GABA receptors, and there's a GHB receptor, funnily enough, that causes excitatory effects. So the sedation you get with GHB, so pure GHB toxicity in and of itself will cause respiratory depression, but rarely a respiratory arrest. But the problem is it acts synergistically with other depressants, mostly alcohol, opioids, so you can have a synergistic reaction and lose your airway on GHB when you combine it with other sedatives. Your typical GHB sedation, so people will be almost GCS3, rapidly rouse and then resedate. Myoclonic jerks are fairly common, and really it's just supportive management to get it through. The decision to intubate should not be based on GCS. The decision to intubate on GCS mainly came from trauma research. That whole thing, If the GCS is under 8, then you intubate. And as much as I love basing my practice on rhymes, there's not a lot of evidence. Based on airway protection, oxygenation, don't just base it on GCS, you up it. Does anyone know this consultant? Anyone work on the Gold Coast? If you intubate a GHB overdose as a reg on that, you will get told off. They used to intubate them all the time, but now they're moving away from it. But I think it's the vigour of this is a little bit overstated, even in Cairns. More take this guy's approach. Something to be aware is GHB withdrawals are nasty. It's a lot more potent on the GABA receptors than alcohol. And if you're taking more than 4 milligrams a day, your risk of withdrawal is quite high. And the more you use per day, the worse it gets. And there are people who are severely addicted to GHB. It presents often like alcohol withdrawal, but it's a lot more severe and hard to treat. And the problem with GHB is you can't just go to your local bottle shop and get a bottle of GHB. So if somebody's dealer isn't able to supply, they may go into withdrawal. It's not uncommon on the medical or the surgical wards of people in hospital to go through a GHB withdrawal, and it's not something people tend to disclose on arrival to hospital. So just keep that in mind. If you treat it like an alcohol withdrawal, you'll probably be fine. Benzos are first line, but phenobarbital is often the required agent. Solvents make me feel sick, they really do.
Devil ether. It makes you behave like the village drunkard in some early Irish novel. A total loss of all basic motor skills. Blurred vision, no balance, numb tongue. The mind recoils in horror, unable to communicate with the spinal column. Which is interesting because you can actually watch yourself behaving in this terrible way, but you can't control it. You approach the turnstiles, and know that when you get there, you have to give the man $2 or he won't let you inside. But when you get there, everything goes wrong. Some angry Rotarian shoves you and you think, what's happening here? What's going on? And you hear yourself mumbling, "So expect control? No fault on my end?"
Alright, so solvents, physiological toxicity, high, medium, or low? Yeah, reasonably high. Death by misadventure, you're pretty much on the ground, so it'll probably be around here. When I first saw this, so where all the deodorant cans are locked up, I just thought, wow, this town seems a bit run down and a bit shitty, but people really care about their personal hygiene. I was really disappointed to learn the actual truth. So solvents typically are volatile hydrocarbons. Toluene is pretty much the main one, but butane, propane, the propellant in aerosols, petrol, if anyone was in the Northern Territory in the 90s will have seen this. And about 1% of people use it per year, and it's very common amongst teenagers without money, without contacts. This is probably the most intoxicating thing they can get their hands on. And it's associated with about 8 deaths a year. And the main thing to be aware of is sudden cardiac death. And rarely asphyxiation. If you stick your head in the bag of glue, it might cause a problem, but sudden cardiac death is the one that I think a lot of the paramedics should be aware of if they're called to a scene of solvent toxicity. So the reason for this is the solvents affect cardiac ion channels, in particular the calcium channels, and makes the myocardium very susceptible to catecholamines. So what will often happen is the teenager is caught sniffing, they're startled, they run, they have a huge catecholamine surge and it precipitates a VF arrest. There's probably a lot of other arrhythmias that occur that are subclinical, But if you get to the scene of a solvent arrest, then immediate defibrillation is life-saving. Just get the pads on immediately, as that's probably the most likely cause. And the thing that really does make me feel ill with solvent abuse, just with the young brains, is the huge cognitive impairment. Having seen a lot of the adults in Alice Springs through the Northern Territory who are petrol sniffers as teenagers, and absolutely devastating effects, just is really sad. Basically, the solvents cause widespread lipid peroxidation and destroys your myelin throughout the brain. So cognitive, motor, sensory, it's all really wiped out and completely irreversible. Does anyone know? Can anyone pick the movie? Or am I just showing my age? Trainspotting! Yes, I'm not the oldest person in the room. Great. So, if you've slept through most of the talk, I would advise you to wake up just for this section, as this is really going to change Australia. Potentially from a social and political field. Some of the novel opioids that are coming through are absolutely terrifying. So in Australia, most opioids are from medical diversion, and this is just your gentle, happy, gentle little endone. Nothing to see here. Been implicated in about 800 deaths of opioids in 2023. Pharmaceutical sources far outstrip the illicit sources, but I'm almost certain this is going to change in a really bad way. And we're going to follow what's happened in America. So in America, for those that don't know, there's been about 250,000 deaths in the last 5 years from illegal fentanyl coming through from the Mexican border. And I'm not a Trump fan, but I think cutting off that is actually one of the few good things that man has done, because when you've got 250,000 people dying, something should be done, and it doesn't seem that politicians really care about junkies, but Trump has. I don't know, it's weird. And something I really want you guys to take from this. Now, most people here, middle class, do not move in circles where opioid abuse is common. Now, there's a study in San Francisco that looked at 40% of opioid fatalities occurred in people not intending to take opioids. So it's been mixed with cocaine, MDMA, and ketamine. So even if it's not in your circles, it may well be, even if you don't use those drugs, in people you associate with might. So just be mindful that this is coming, and it's going to come in a hard way. Opioids, physiological death. Death by misadventure, pretty low. Now, the novel opioids that's most around in Australia are called the nitazines. So they were initially synthesized in the 1950s, but they were so horrendous and toxic that they never made it through, but some clever person has dug through the archives and reinvigorated them. There's a lot of different subtypes, there are different half-lives, different potencies, so you're not really sure what you're dealing with. Apparently you can get a gram of this on the dark web for $200. I've never tried it, but it seems very cheap because it's as potent as fentanyl. There's 40 deaths in Australia, but it's likely to be higher because a lot of them weren't tested for it. And of concern is that they do not show up on fentanyl test strips, so a lot of people who are using things like ketamine, MDMA will test the drugs for fentanyl, but this will not show up. And wastewater confirms that they are in all areas of Australia. So, clinically very similar to fentanyl. Some are more potent than fentanyl, so considering 100 mics of fentanyl will probably put most people here into a very, very deep sleep. So 1 gram, that 1 gram that costs $200 is 10,000 doses. The really concerning thing is that it doesn't just wear off like fentanyl. So depending on the subtype, 2 to 8 hours is your time frame for respiratory depression. And this is because they bind quite tightly to the opioid receptor, so they're harder to remove with naloxone, so they bind quite competitively. So you often need much higher doses, and due to that long half-life, you often need an infusion. We'll go through naloxone dosing in a little bit, but when you think about the economics of this drug, if you can get a gram for $200, it contains 10,000 doses that last up to 12 hours. If you were a bit of a tightwad and you wanted to set yourself up for 30 years, you could just take one dose of that a day, be off your chops for 12 hours, assuming you don't build tolerance, and in 30 years you'll run out. So when you think about how hard it is to get a gram of a substance through customs, it's pretty easy. You don't need a narco sub bringing 9 tons of this to make a fucking shitload if you're a drug dealer. So this scares me, it's coming, and it's going to hit hard. Does anyone recognize these pictures? Yes, the Russians, yes. So the Chechen rebels stormed the Russian theatre and held about 350 people hostage. The Russian special forces decided they would gas people with carfentanil and killed 130 hostages. It all sounds a bit different in Russia. They didn't think to bring naloxone to this party. Maybe they should. They didn't tell the local hospital what they'd used. So they just all these unconscious people who killed 130 people essentially by spreading carfentanil through the air conditioning duct. If you think nitazene's a bad, carfentanil is its evil twin. So 1 microgram is potentially lethal. That's its equivalent of 100 mics of fentanyl. So 1 million doses in that 1 gram. Its half-life is 6 hours and its active metabolites are 11 hours. So 18 hours of sedation from this bad boy. It's a bit more expensive, $3,000 a gram, but if you're going bang for your buck. And unfortunately, Queensland Police found this in a raid in 2025. Now, I'm not sure what's keeping these drugs out of Australia, but I really hope it keeps up. Because as I said, you don't need a submarine to bring this in. It's so potent, so dangerous. Things are trickling in, but my fear is that this is starting going to hit in a big way. So in terms of your management, so titrate your naloxone. So an infusion should be about 2/3 of the initial dose to reverse sedation per hour. Something I think would be good for ED nurses as well as respiratory rate is often underestimates the level of respiratory depression. So with opioids, you mainly drop your tidal volume rather than your respirate. So you might be sitting with a respirate of 10 or 12, but you're moving very little gas. And it's very quick to desaturate. As soon as that CO2 starts building up, I won't go through the alveolar gas equation, it's supposed to be a fun conference. But as soon as the CO2 starts building up and your respirate is low and your ventilation is low, people can desaturate really quickly. There's some controversy of whether you give supplemental oxygen. I will always give supplemental oxygen. People say it might mask hyperventilation, but I don't care about hyperventilation, I care about hypoxia. And if you work in a busy ED where your nurses might get diverted to a trauma or something else, and they're not watching your patient closely, having supplemental oxygen will get you through. If their CO2 rises, they breathe lovely supplemental oxygen. And even if their pH drops, I don't really care, because it's not ideal, but we always hear that acidosis is bad, especially in trauma, etc., or sepsis. Things like it will drop your coagulopathy, but the chances are that opioid overdose doesn't have a lacerated spleen or an open pelvis that needs a coagulation. If their pH drops to 7.1, I'll take the risk rather than missing out rapid deoxygenation. This guy, does anyone know what this is? So this is intranasal naloxone. It's free, without prescription, Australia-wide. This will be a lifesaver, and I think in a few years' time, almost everyone going out in the town will have one of these in their pocket. I want to reiterate that study from San Francisco that 40% of opioid overdoses did not intend to take opioids. Now the fun bit, LSD. Physiologic toxicity? Very low. No recorded deaths from LSD ever. Death by misadventure? Oh yeah. %, used in the last year, typically younger people, no deaths ever reported due to toxicity. Lasts for about 8 to 12 hours. The pharmacology of LSD is quite interesting. So a lot of it is serotonin in the cortex, but it has really interesting effects on the thalamus. Now, I won't bore you with it, but the thalamus acts as almost like the signal junction of the brain, and LSD opens that up. So things that your thalamus would normally filter out are actually able to be processed. And a classic example of this would be if you're in a cafe or bar and somebody says something you're familiar with, like your name, a friend, somewhere you work, you can actually tune into that and remember what they said a few seconds before. So that's the thalamus cutting out the noise, letting through the signal. LSD breaks that down and it allows connections with different parts of the brain that normally don't occur. So it kind of bypasses your cognitive shortcuts that you use, so you can be a lot more aware of things that you're not normally aware of. Hence why a lot of the Silicon Valley people microdose to help with creativity. Non-addictive, generally safe, but can be quite terrifying when it goes bad. So, unlike MDMA and methamphetamine, you could take that in a sewer and still have a great time. LSD just basically turns up the gain on everything. So, things that are nice become amazing. Things that are not so great become fucking horrific. It opens up parts of your brain you don't normally use, lets you know things about yourself, and people can have really bad trips. And having dealt with a few LSD psychosis, they are so much worse than a methamphetamine psychosis. I find that the meth heads, usually you can have some reason, there's still some connection with reality, but when I've seen a true terrifying LSD psychosis, they feel they're dying, they're fighting for their life, nothing you can say or do will actually get you through, and they are so hard to sedate. And they're really hard to sedate with droperidol, as it's a serotonin, LSD works on serotonin. So by blocking dopamine, you don't really treat the true synaptic cause of the psychosis. However, risperidone and olanzapine are both active against the serotonin receptor. So I've had people who have been absolutely off the wall and have managed to get some sublingual risperidone into them, and about 10 minutes later they've apologised, cried, and wanted to go home. Olanzapine is a bit more commonly used in EDs, and it's not quite as good as risperidone, but it's still very effective. So that would be my go-to. Droperidol may help, but don't expect too much from it. So yeah, hit it where it's active. Ketamine. Most people know this one. Some people know this one. About 1% used in the last year. Can lead to dependence, and some people are fairly regular users, mainly higher social economic groups. About 20 polypharm overdoses involving ketamine. Where do we put ketamine? Physiological. Pretty low. Death by misadventure. Pretty low. I really like Matthew Perry. I thought he was hilarious as Chandler Bing. Unfortunately, Matthew Perry did to ketamine what Michael Jackson did to propofol. And the amount of times I've had to counsel a parent through giving their kid this murderous drug. Numerous occasions. Now, for those that didn't read the coroner's report, Matthew Perry injected ketamine in his bloodstream at 4 times the amount of a general anaesthetic dose. He did this in a spa by himself. Leave my mate ketamine out of this, okay? Please. So, I had this case in Cairns, not this guy, but similarly spunky. A 28-year-old French backpacker complaining of dysuria, frequency and leukocytes on his urine. clear-cut STI. Absolutely. He had a test about a week prior in Townsville that came back negative, and his urinalysis had no growth. Anyone know what's going on? Yeah, ketamine cystitis. So it occurs in about 30% of recreational users, and it triggers an autoimmune inflammation of the bladder and chronic use can lead to ulceration, fibrosis, chronic urinary dysfunction, and certainly in areas of the world where ketamine's a lot cheaper than Australia and people are using a lot more, people are actually having their bladders taken out, having ileal conduits placed because it can get really bad. It can also affect the ureters, leading to hydronephrosis, and can even affect the biliary system. So when you have someone who doesn't really fit with UTI or STI, checking their drug use is really important, and the only treatment really is abstinence. Going from this spunk to this spunk. Does anyone remember a trend from Punchy? So nitrous oxide, I think we're all pretty familiar with it. We know it's low toxic, but people laugh, they giggle, they talk to God, they do everything in between. So the pure drug, especially ED, very low risk of toxicity, very low death by misadventure. But there is a few things that you need to be aware of. So 2% used last year, again, often teenagers, as you can get it fairly cheaply and readily, and it's usually 0 to 5 deaths per year. A combination of hypoxia and barotrauma. So one of the dangers of these, so these dispensers, so they use for cream chargers, the nitrous goes in here, fills this bottle, they pull this trigger and it comes out here. This is usually about 500 mil to a litre, and people typically use 1, 2, maybe even 3 chargers per time. So if you're using a 500 ml container to chargers, that goes up to about 15 atmospheres of pressure. And when you release, the trigger comes out at about minus 50 degrees. Now, if you're cautious and you know what you're doing, you just pull that down gently, it's fine. If you're a bit cooked, and you ram this down because you're not afraid of risk, you can expose your airways to 15 atmospheres of pressure and minus 50 degrees gas. So pneumothorax, pneumomediastinum, but a lot of laryngospasm and bronchospasm can result. So again, a lot for the paramedics. So somebody's looking at respiratory distress from nitrous oxide. It's not the nitrous oxide, it's the way they've taken it. And sorry, just go back. Nope. The other hypoxia, it's usually not by cream chargers, but it's people who are a bit more addicted who hook it up to almost like a non-rebreather mask, so they're having continuous flow and cause hypoxia.